Good morning, everyone. Welcome all of you joining the public presentation organized by the Occupational Health Center. Today, the topic is about protecting workers in the pandemic. What needs to be done about the airborne transmission and why? So we are so grateful to a group of members from the Canadian Aerosol Transmission Coalition is going to present for us. I'm going to introduce them, one by one. First of all, we have Marianne Levitsky. She is the occupational hygienist and founding president and current board member of the Workplace Health Without Borders. She is also the adjunct lecturer at the University of Toronto and works with the ECOH Management Inc. It is an Ontario-based consulting firm. Next, Laurence Svirchev. He is the certified industrial hygienist with the background in managing health and safety on international multicultural infrastructure development construction site, occupational cancer, epidemiology, earthquake disaster management research, and also as a WorkSafe BC occupational hygiene officer. And the next one is Stéphane Bilodeau. He is the ventilation engineer with a PhD after his name, Fellows of Engineers Canada, and the co-founder and chief technology officer for Smart Faces Inc. These days, he is an active member of the ECHO's co-ed staff, Zero Co-ed Canada and Coalition of Aerosol Transmission, and the coordinator of the World Health Network's Indoor Air Quality Task Force. The next speaker is Simon Smith. Despite his recent retirement from the 35 years career designing respirator filters and the test methods, Simon is also involved in leading roles with development of respirator standards for Canada and internationally. A past president of the International Society for Respiratory Production, he's also participated in various industry organizations and is currently working on the new respirator performance standard for Canada and the new tools to make standard more accessible for the respirator user. And last but not least is Dorothy Rickmore. She's also the occupational hygienist here, the first occupational hygienist here in OHC here. And also Dorothy is a mapper, ergonomist, stress specialist, educator, and researcher, and right now living in Ontario. And aside from the volunteering with the Aerosol Transmission Coalition, during with the pandemic, she has written worker-friendly materials for US education unions and also the OHC, being inspired to write a book about workers' experiences in the pandemics as a result of government failures to accept airborne transmission and precautionary approaches. So we would like to also begin that we would like to begin by acknowledging that we are on the Treaty 1 territories. The traditional territory of the Anishinaabe, Greek, OG Greek, Dakotas, and Diné people, and the homelands of Métis Nation. We respect the treaties that we were made on these territories, and we acknowledge that we are all treaty people. At the Occupational Health Center, we commit ourselves to a process of reconciliations with Indigenous communities. So for the chat and follow up, how to participate in this session. To ask the question, please put your answer in the chat box area on the right side of your screen. So the presenter will try to answer it at the Q&A session. But however, we may not able to cover all the questions. Would you please follow up afterwards? That would be really appreciated. And also you notice that this event is being recorded for viewing later. And also for the chat and resources, you have been broadcast on the chat is also recorded. We could share with you as an attachment as well. So please also participate the follow-up evaluation survey, giving us some feedback for the future events. Occupational Health Center, we are the community health center funded by the Winnipeg Regional Health Authorities. We are now currently located on 167 Sherbrooke Street, Winnipeg, Manitoba. So we provide the services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committees for training. Please visit our website for more information and resources. So please join me to welcome the first speaker, Marianne, to talking about what is the coalitions. So Marianne, I give you the floor to you.
Thank you very much for inviting me. I really appreciate this opportunity to speak with you. I'll just get my slides up. Hang on one sec. It's not going into slideshow mode, so just give me a minute. For some reason, it's not going into slideshow mode, so I might need to just show it like this. Can you see the slide as it is?
And yes, we can see your slide, Marianne.
Okay, sorry, I don't know why this is happening. I'm actually going to stop it and try again. So
sure.
I like to put it in slideshow mode. I don't know why it's done this.
This always happens, right?
Yeah.
Good old technology.
Yeah.
If you like, Marianne, I might be able to share yours.
Yeah, if I keep clicking slideshow and it keeps exiting. One more try, and then I'll go with Dorothy's solution. No, it's not working. So I can either show it from the screen like this or with Dorothy, but maybe since it's not a very long presentation, I'll just advance to each slide in this way. So thank you again, and I'm very sorry for that glitch. Oh, okay, Dorothy's showing it. Okay, good, thank you, Dorothy. Good, thank you so much. I'll have to say next slide. Okay, so we are the Aerosol Transmission Coalition. Again, thank you very much. I'm sorry for that glitch. We don't usually have them. In this, in my short presentation, I will just introduce you to the coalition, and then my fellow speakers will talk about specific aspects of aerosol transmission. So next slide. But since we're just getting into this is a different version. I had an initial slide talking about aerosol transmission, which is not in this version. So I will just give you some basics, and I know that Laurence and other members will be talking in a lot more detail about it. But our main concern is that COVID is airborne. That initially, as you can see from this graphic from the WHO, that orange graphic there, from the very beginning of the pandemic, they were adamant that it was not airborne. But we know now that when people speak, sing, laugh, talk, even breathe, they emit particles or droplets or aerosols in varying sizes. And these may settle quickly, but they're more likely to float in the air for a long time. And when they reach a critical concentration in the air, people might inhale them, and if they contain virus, they may become infected. So as we see here, WHO, the World Health Organization, did not recognize this at the beginning of the pandemic, but it was certainly recognized by other people from other disciplines, including aerosol scientists and occupational hygienists. So we see here the things in white are the little clips of attempts by people to make this point from very early on in the pandemic. You can see that Lindsay Marr, an aerosol scientist, was saying this in March of 2020, before even the pandemic was declared. The president of Workplace Health Without Borders, the organization I'm involved with, wrote to the Minister of Health and Dr. Theresa Tam in April of 2020 with similar messages. And then perhaps the one that got the biggest splash was when 239 experts signed a letter to WHO, and it was published in Clinical Infectious Diseases in July 2020. So people have been saying this for a long time. It's taken a long time to get some recognition of that fact. Next slide, please. So as you saw, there were a number of us all saying the same kind of thing, pretty much from the beginning of the pandemic all through 2020. And towards the end of 2020, we kind of found each other. There were some doctors, I will introduce them to on a subsequent slide, who were writing a letter because they were concerned as healthcare workers that they were not being properly protected against aerosol transmission. And they were concerned as well as parents that children in their schools were not adequately protected. And they started writing a letter, and people like myself and Dorothy and Kevin, occupational hygienists, and Laurence, kind of who had been saying the same thing, kind of found each other, and we all kind of came together around that letter, which was published in January 2021. But we decided to keep on meeting with each other and try to raise our voices even louder and be heard. So we have been meeting almost every week virtually. We wanted to apply the lessons of the Campbell report from the first SARS crisis, where we became certainly adamantly in favor of the precautionary principle, which says if there's uncertainty, err on the side of caution, essentially. We had good reason to fear that aerosol transmission would be ignored again, and with it, all the kind of precautions you need to protect workers from what's in the air. Next slide. So here's most of our members. I'm not saying they're all here, but I think the main point is that we're a very multidisciplinary group. So we have physicians, we have engineers and ventilation specialists who will talk to you today, an expert in respiratory protection who will also talk to you today, Alec Farquhar, who's kind of been a key leader and organizer, who's a lawyer and very involved in OHS regulation and enforcement, and a number of occupational hygienists. We have really, and of course, a microbiologist, Raymond Tellier, who has really helped us a lot with scientific understanding of SARS-CoV-2. I think, you know, as hygienists, we find that we too often do not talk to enough people outside of our own discipline. And one of the most gratifying things about this coalition, and I think that's something that has held us together and is responsible for any success we've had, is that we are so multidisciplinary and we really benefit from cross-fertilization of our various perspectives. The next slide. Not only do we have a number of different individuals, but we have a number of different organizations that are involved with the coalition, and you see some of them here. People who will speak to you today are with a number of these different organizations. I'm with Workplace Health Without Borders. Some of the others are with Zero COVID and COVID Stop. Next slide, please. So we mentioned the first letter that we published in January 2021. We had a second letter published in February of that year. And we've also had some pretty good media coverage ever since then. Quite a few of our members have been interviewed by newspapers, by broadcast television, and in a lot of different places and webinars. And I think there has certainly been growing recognition by the public as well as the media of the messages we are trying to convey. The next slide. As you can see, this is even more examples of some of the media coverage we've been getting even up to very, very recently. Next slide. Now, despite this growing recognition, I'd say there's been a lot of resistance on the part of Canadian authorities. These slides are from a presentation given by Mario Posamai. It's online. And he was extremely active in the initial SARS. He was worked for the SARS Commission in the initial SARS pandemic, and has been very active in this one as well. And he's pointed out some of these quotations from infectious disease community and people who've been resistant to the messages we're trying to get across, that essentially say, our messages about aerosol transmission are a tempest in a teapot. One even said we were promoting unfounded conspiracy theories. We certainly hope that gradually these kinds of ideas are being laid to rest, and there is growing acceptance even among authorities that aerosol transmission is real and must be countered and prevented. Next slide. So since the publishing of our letters, we've been engaged in other advocacy efforts. We have appeared before the Ontario Science Table, which certainly has a lot of visibility in Ontario, as an advisory body to the government, and communicated our message there. We think it has been heard. I'll tell you why in the next few slides. We also advocated against a study that we felt was unethical. It was a study that was purporting to be a randomized trial using surgical masks versus N95 respirators. We felt that we knew that N95 respirators were more protective, and therefore it was not ethical to give one group in the study inferior respiratory protection. And this has been covered in the media as well. Next slide, please. So here's some of the successes, maybe. There's been some dispute about how much success we have had. But I mentioned the science table. Peter Uni, who's the head of the science table, interestingly has kind of shifted his messaging in recent weeks. Has been quoted very frequently in the media about airborne transmission. And this is a quote from the Toronto Star. He says, transmissions of this virus is airborne, very unequivocal. And it loves people inside crowded spaces that aren't well ventilated. Certainly a message about ventilation that we've been advocating from the very beginning. And we even have Theresa Tam, head of Public Health Agency of Canada, now tweeting and saying on the website that there is evidence of aerosol spread. And aerosols can linger in the air like smoke. So we have seen a shift in public health messaging, unfortunately, not from everyone in authority. We also see that governments are funding better ventilation. And to us, this is an implicit acknowledgement. Even if they don't say they acknowledge airborne transmission, why would you fund ventilation as a COVID prevention measure if you did not think it was in the air? So even if they don't say it, we think that the funding of better ventilation, especially in schools, is implicit acknowledgement of airborne transmission. Next slide. But we have a lot more to do. Oh, just go back to that previous slide. Yeah, we have a lot more to do. We still have incidents like school boards suspending teachers because they wear proper respirator like an N95 instead of the surgical masks that are handed out to them. Some of our members in kind of different capacity have advocated for the teachers who are asserting this right to wear proper respiratory protection. We also have Ed Tubb, who's a Toronto Star reporter, reporting on incidents inside hospitals where even to this day, it's been denied that hospital outbreaks are due to aerosol transmission, and hospitals just insist on droplet and contact precautions, even in the face of outbreaks that seem fairly clearly to be caused by aerosol transmission. So we still have a lot more to do in this regard. Next slide, please. So what else are we doing? Well, we need to continue this advocacy for airborne measures, prevention measures. We're partnering with more organizations, and we're starting to talk about calling for an inquiry into the pandemic so we can air what went wrong and try to make sure this does not happen again. So with that, I'm going to turn it over to some of my other colleagues to talk about some of the details.
So next, we will invite Laurence to cover about the prevention plans based on the aerosol and airborne transmission. Laurence.
Great. Thank you very much, Marianne. Okay, can you see my screen?
It's good.
Good. Thanks very much, Marianne. That was a great presentation, and I'm very happy to be presenting to this group this morning. So I'm going to concentrate on protecting workers in the pandemic, with a special emphasis on one industry as an example of achieving a zero infection rate due to SARS-CoV-2. So let me put it this way. A zero occupational infection rate from the hazard of SARS-CoV-2 is a necessary, reasonable, noble, and achievable objective. It can be done in workplaces. The mode of transmission of this virus is the inhalation of infected particles that are exhaled by asymptomatic or symptomatic people. And these particles are called aerosols. I'd like to go back to the dean of aerosol physical science, a gentleman by the name of William Hines, who was deceased this year. He wrote a book called The Properties, Behavior, and Measurement of Airborne Particles, in which he defined an aerosol as a collection of solid or liquid particles suspended in a gas. So that's a physical science definition of what an aerosol is. You will notice that a great distinction seems to be made between droplets, that is, larger particles that come out of the respiratory system, and smaller particles, which are traditionally called aerosols. But if we go back to this definition of William Hines, we'll see that what is traditionally known as a droplet is also something that comes out of the respiratory system. It passes through air, and it's also suspended in gas, in the air, in the atmosphere we breathe. Now, it might fall down sooner than the aerosols, the smaller particles, but nevertheless, it does pass through air. So there is a somewhat of an artificial distinction that is made. Scientists call this dichotomy between aerosols and droplets. And I'm going to treat them as one and the same, but different sizes. Every workplace and each task needs a specific safe work procedures to prevent workers from carrying the virus into and out of the workplace. And the reason I say specific is that different jobs entail different exposures. Someone who is a cashier in a retail outfit, in a retail store, is going to have a different exposure conditions than someone who is working in a meat plant, for example. The difference being that meat plant workers are working very close to each other. They're in much more humid condition, humid, H-U-M-I-D, humid conditions than a typical retail store. A teacher in a school or a student in a school is going to have a very different exposure profile than that retail clerk or that meat plant worker, or a miner, for example, a miner in an iron mine. So specific safe work procedures have to be done. And those are employer responsibilities. They're not just employer responsibilities, they're also worker responsibilities. And they're also Joint Occupational Health and Safety Committee responsibilities to determine the best method of controlling any hazard in a workplace. Let me jump for a moment to the international situation. This is data that comes from the World Health Organization. It's up to date as of this week. And in this slide, what myself and a colleague did was we took WHO data and we looked at the population rate in every country in the world. So this slide shows some data that we picked out of the entire data set. And in the left-hand column, you see some of the major countries with different infection rates. And if you go over to the column in cumulative cases per 100,000. So this is a population-based rate. Of course, a country with a larger population is going to have more cases than a country with a smaller population. So comparing Sweden to the United States in terms of case numbers or fatalities is a bit of a false comparison, but if we adjust for population and get a population rate, then we can compare one country with another. So if you take a look at the cumulative number of cases per 100,000 for the United States, and this is for the whole pandemic, 14,587 cases per 100,000 population. We then converted that into a relative risk relative to the international average. The international average global would be 1. So the numbers in red, 4.3, 3.1 for Brazil, all Europe 2.9, Canada 1.4. That's increase over the international average. So the United States actually has, for major countries, has the worst rate in the world. Canada has a 40% excess over international average, 1.4. Canada as a whole is not doing a good job. You would expect we would with the resources we have as a country and our healthcare system, but we're not. On the other hand, if you go look down to the greens, Japan, 0.4. A country like Korea is doing very well. All Africa, 0.2 over the international average. I've left that in black, not green, because there are consistent problems with underreporting from that continent. New Zealand, which has an economic and social system very similar to our own, is doing quite well, 0.1 of the international average. In China, they're doing very, very well. I think yesterday they had something like 34 cases in the whole country. So I'd like to point out that each of these countries that are doing very well have different governmental systems, history, culture. But what they have in common is an attempt at an elimination strategy. They have strong centralized leadership, which exercises detailed control over not only generalized public health measures, but occupational health measures. And finally, I use this word a lot, they have a socially disciplined citizenry. In general, they have a socially disciplined citizenry that understands the prevention measures and takes account of them and behaves accordingly. For the transmission of SARS-CoV-2, a number of scientists have conducted what appear to be fairly simple experiments to show the aerosol transmission. And here's a good example from Qatar. This is March 2021, so fairly recent. And at the top, you see a ferret that has been deliberately infected with the virus. And this ferret has sat for 24 hours in the cage, breathing through a system. Sorry, I got that backwards. The one on the bottom is the ferret that's infected initially, sitting in the cage for 24 hours. And the airflow is going up this tube, which is about 1 meter long, into the above cage. So the bigger particles do travel up through that tube, what are traditionally called droplets, but the aerosols, of course, are going up. So this is a closed system. So infected to affected, infected, infected to previously uninfected. The ferret in the top becomes infected. The only thing that's coming out is the breath of the air of the one on the bottom reaching the one on the top. So that's a good example of aerosol transmission in an animal experiment. And in this slide, I show something that came out just a month ago in the something called a computational microscopy model of an aerosolized viral particle. Using an incredible array of resources, these scientists found that were able to examine and develop a model of an aerosol at the atomic level. What you see here on the right-hand side is an aerosol that comes out of the human system, and inside of it, in purple, is the SARS-CoV-2 virus particle. And these are, for those of you who have followed it a little bit more deeply, these are the spike particles that actually attach to human cells and cling to lung cells and provoke the virus. And on this side, you see how the particles can enter into the respiratory system. So the science, which by the way has gone back to the 1930s, has accelerated extremely rapidly to show aerosol spread. So now I'd like to turn to how do we assess, how do occupational hygienists assess the occupational environment and risk. Now, the normal method for risk assessment for any substance in a workplace is to measure airborne concentration over time for different hazardous materials, and we measure them if we can. However, occupational exposure limits for biological agents do not currently exist. To date, there are a limited number of validated methods even to measure airborne or surface contamination of infectious agents. So we can't measure them, or they're very, very difficult to measure except in a laboratory situation. So here are some of the characteristics of the SARS-CoV-2 virus. It's novel, which means it's new. We've only had 20 months or so to understand this thing, this beast. Made incredible progress, but novel means there's a lot we don't know. It causes a highly infectious respiratory disease. The sources of infection are mobile human beings. It's not like the pile of asbestos or sawmill dust that's over in the corner. It's not a typical respiratory hazard. This is something that moves with human beings and it's generated by human beings. And those human beings can be symptomatic or asymptomatic. Asymptomatic means we don't see the symptoms yet. They don't know they're infected and we don't either. The turbulent gas clouds are generated. So you have multiple workers walking around in a situation or multiple people going shopping, and multiple people are generating turbulent clouds. Particle sizes are inhalable and respirable. Inhalable meaning they go to the upper portion of the lungs, respirable meaning they go to the deep lungs. We don't know what the infectious dose is. And previously, there was no pharmaceutical intervention, also known as a vaccine. There's an older model that can be used to characterize how we deal with workplace hazards, and this is called the Swiss cheese barrier model. So in this model, you see that each workplace layer is conceived as a barrier or a layer, each workplace control, and each one of those barriers or layers has strengths and weaknesses. So a weak control would have a large hole, and the aerosol could pass through easily. If the holes are lined up, the bioaerosol can enter the respiratory system and infect the person. If the holes don't line up, the bioaerosol probably cannot enter the respiratory system and infect the person. So here are some examples of different kinds of barriers. And this is just this is not all inclusive. These are just some examples that we can use in a workplace to prevent infection. So many workplaces use a QR code, which is a self-administered health check, in order to say, hey, I don't have signs and symptoms of the disease today. I can go to work. I can enter the workplace. This is a weak barrier with large holes because of self-perception bias. Self-perception bias means either I don't know I have the disease, or, I'm not feeling so good, but I'm going to go to work anyway. A second example would be a surgical mask. So that's a moderate barrier with large holes. And I say that in a double sense. It's in the Swiss cheese model, a surgical mask would have large holes, but also a surgical mask does not fit tightly with the face. So it, in fact, has portals of entry, even when it covers the face. Another barrier would be regular testing. So in this model, regular testing would have smaller holes. It would be a strong barrier because now you have a medically objective measurement of whether a person is infected or not. And vaccination and ventilation would have very small holes, and they would be very strong barriers against the virus entering the workplace. So now I'd like to turn to a practical example of an international film production in Canada. I was the COVID compliance officer on this particular film project, so I have direct knowledge of what went on there. The production duration was for 5 months, from September of last year to January of this year. For those of you who are not familiar with the film industry, film is typically done indoor and outdoor. So indoor would include a studio, office buildings, residential homes, schools, and town hall. An outdoor setting for this particular one, we were in riverbanks, we were on forests, we were in farms, we were out on residential streets, and there were even some scenes on speedboats. So multiple environments for exposure. So I ran into a little problem there with voice control. Okay, this particular, all productions are unionized. As I said, this happened over the course of 5 months. We had about 500 workers per week, including extras. Very long days, 12 to 16 hours per shift. In this production, we had we called an A zone. This was a hot set. PCR testing was conducted twice a week for the following groups of people: the performers, the directors, sound, lighting, camera, hair, and makeup, people who had come into close contact for less than 15 minutes during performance or preparation. Our A group, which was tested twice a week, was senior management, doctors and nurses, staff, and myself, the COVID compliance officer. We also had a group called the B zone workers, and these were tested weekly. These are mainly, you could say, manual workers, change the sets and equipment in between takes on the set. They were only allowed into the hot zone, zone A, with masks on. And the COVID team, these were B zone employees who deployed hand sanitizing stations, sanitation, signage, and other tasks. And then a group of drivers, food service workers, carpenters, painters, and set designers. They were C zone workers and not tested. Our program, because we did testing on a regular basis, exceeded the minimum requirements of WorkSafe BC, which is the BC provincial OHS regulatory body. So I'd like to take you through what we did from the beginning. Step one, the international prime contractor, the studio, in agreement with the unions, sets out the COVID-19 prevention program and expectations for each production. So understand the production, the studios, the people who really own the project were located in the United States. These studios are operating in the United States, they're operating in Europe, they're operating in Canada. So a multicultural workplace, and everything had to be established in coordination with the union according to the contracts of the different unions. In step two, the organizational and infrastructure issues at each production included a constant modification of script to meet COVID-19 compliance requirements. Now understand that people who write scripts in movies, they want to do all kinds of things that would put people into very close contact for extended period of time. So actually the movie script writers had to be trained in the COVID requirements. And we had constant back and forth discussions with the script writers about, hey, we can do that, but we can't do what you just suggested because that would violate our protocols. We got a contract with a PCR testing laboratory right away. And that was important because when caseloads increased and the labs were overloaded, we were first in line. So a very important decision was made about making sure that all the employees in A and B could be tested without shutting down the production. We also had a regular medical doctor and nursing staff, myself, the COVID compliance officer, to make sure that when questions came up about, hey, what are we doing here? What are we doing there? That we could make suggestions of input based on our medical and our exposure assessment knowledge. MERV 13 filters were installed in the studio ventilation system. I sat through all the orientations of subcontractors. And I just want to say that the subcontractors, the workers, the people who did the actual work were all in accord with very stringent requirements. There were lots of people who might have had their personal opinion, but everyone would say the same thing. I want to keep working. I don't want to get this disease and I don't want to bring it home to my family. So there were some success factors for the results that I'm going to show you in a moment. At the management level, there's coherent planning and coordination between the management, creative, COVID, medical, and the compliance teams. There was constant surveillance, education, and sympathetic listening by the nurses, the medical doctor, and at the level of workers, management, and creative teams, we had a common vision that SARS-CoV-2 could not enter the production. No worker was allowed to be infected. We had social discipline. No worker wanted SARS-CoV-2 to enter the workplace or take it home to their family. One of the really creative things we did was 1 week before management, the senior management leader came to work one day and said, "Hey, Laurence, I woke up at 4 o'clock in the morning with an idea. We're going
Sorry
to
for interrupt you, Laurence. Would
Yes.
you mind to wrap up your part in 2 minutes, because we have another three speaker need to present their section. Sorry about that for interruption.
I'm very close to the end. Thank you very much.
Thank you. Yeah.
Workers were disciplined enough to the point that those who really did not agree with what we were doing, somehow they didn't come back to work. There was a lot of social pressure within. Hey, you're misbehaving, please. Maybe you should work elsewhere. We had a 100% success rate, 0 infections for 500 workers per week over the course of 5 months. The production finished on time and on budget. Lessons: every workplace and each task needs a specific safe work procedure to prevent workers from carrying the virus in and out of the workplace. Occupational COVID-19 measures need to be set differently and higher than typical public health measures. Union and worker participation and acceptance of the program is essential for rigorous compliance. It's achievable to get a 0 infection rate. A 0 occupational infection rate helps to lower family and public rate of SARS-CoV-2 transmission. Vigorous use of PCR testing exceeded the minimum requirements of WorkSafe BC. A vaccination program. Remember, the example that I gave you was pre-vaccine, so we didn't have the additional measure of vaccine at that time. Since then, I'm certain that a movie industry production would have introduced a vaccination program as an essential component. The use of easily accessible N95 or equivalent respirators provides superior respiratory protection over surgical masks. And union and worker participation and acceptance of the program is essential to prevent SARS-CoV-2 from entering the workplace. My recommendation is to eliminate the substantial confusion that exists on workplace by education through truly knowledgeable worker representatives and trusted professionals. And I've also given you a list of resources which form the basis of this presentation. Thank you very much.
Thank you, Laurence, for giving us really great informative information, the presentation. Next speaker, we would like to have Stéphane to present about ventilation. Thank you, Stéphane.
Thank you, Tiffany, sorry. I would like to share my screen, so just a second. I think it is right here. You should be seeing it right now. So I'm pleased to be here today from Sherbrooke to talk about the challenges related to the airborne nature of SARS-CoV-2 transmission. In fact, Marianne and Laurence have extensively talked about different consequences of this transmission in the last 2 presentations. But on my side, I will focus on practical solutions for workplaces. I'll talk about precautions, especially those related to indoor air quality and ventilation to help minimize the risks. So we'll start with that in mind. COVID-19 is airborne. It's highly transmissible through aerosols, and especially with the new variants, Delta and Omicron. Omicron that seems to take the lead right now in many regions, even in the neighboring Ontario, by the way, already at or plus or minus 20% of the new cases right now. So let's start with 2 questions. why do we need to improve ventilation? Simple question, simple answer. It's essentially to reduce the risk of exposure to aerosols. So, and we'll see how we can do that later on. And that lead me to the second question. So how can we, in general, reduce the risk? It's essentially by reducing the amount of contaminants, like in any other type of contaminants. Here, it's these aerosols with potential viral load. And the role of ventilation then will be to help through what we call the dilution process. So we'll reduce the amount of these aerosols potentially loaded with virus. So the key here is to see it as a risk management tool. And in fact, ventilation and filtration are part of the engineering controls that we see on the hierarchy of controls on the left side, so the reverse pyramid. So ventilation and filtration are directly there in the middle of this pyramid as an important risk mitigation tool. Indeed, the level of risk is different depending on the setting. Many workplaces, especially schools, restaurants, food processing plant, as Laurence mentioned earlier, are high-risk settings. But we can come back to what we call the 3 C's. The 3 C's, which are comprised of, first, crowded place with many people nearby each other. Second thing is close contact settings. So especially where workers have close range conversation or exchanges. And third, confined and enclosed spaces with poor ventilation. That's the 3rd C. So as shown on the hierarchy controls, engineering control includes the ventilation and the HVAC in general, so heating, ventilation, and air conditioning system, but ventilation especially as an effective is the keyword here, tool to mitigate risk, and even more effective than administrative controls, like, for example, curfew or similar things, and even compared to PPE. But don't get me wrong, PPE are a very important tool, and Simon will talk about that later on. But it's a last resort. It's the last barrier to protect the worker. There are tools that should be put in place before to minimize the risk. And it's coming down to the Swiss cheese layers that was presented earlier. So one of those Swiss cheese layers should be ventilation in a process to mitigate or reduce the risks. Notably, we had seen some papers recently, and one of which published in Physics of Fluids last summer was concluding that, I'm quoting, while higher ventilation capacities are required to fully mitigate aerosols built up, even relatively low air change rates, for example, 2 air change per hour, and I will talk about that later on, lead to lower aerosol buildup compared to the best performing mask in an unventilated space. It's because with ventilation, you address the full space. So all the persons in the room, their risk will have been minimized with ventilation, even a low ventilation. While for masks, which are really great, and other papers, and I will just quote one later on, so are protecting each individual essentially really well. If you have the proper mask, well fit, that will protect really well. And the paper which is quoted in this slide just express that to protect, for example, healthcare worker, FFP3 or similar, between N95 and N99, for example, greatly protect workers. So really well protect them. So, but to protect the whole group, you start with effective measure like ventilation. So let's talk about those precautions and solutions that each and every one of us, each workplaces, each school, each manufacturing plant or food processing plant can put in place, and improving at the same time. So protecting from COVID, but also improving air quality at the same time. So as I said earlier, I will not reiterate that aerosols are the main or dominant transmission mechanism. Extensive studies have shown it, and Marianne rightfully talked and shown different examples of that. But you might just think about Dr. Lydia Moraska's studies with her colleagues, extensive works, which were published last year and then later on as well, that shows the importance of reducing the potentially virus-containing aerosols, and specifically that ventilation is a good tool to have in the toolbox. Many groups, including the ASHRAE, so the American Society of Heating, Refrigerating and Air Conditioning Engineers, which have chapters, many chapters in Canada as well, and many scientists around the world have discussed and shown also that ventilation can reduce the risk. So I'll focus on the main recommendations, the main solutions they're coming with. Indeed, each case is, each setting, each context is different, but there are some common denominators, common ground, and many resources are addressing these generic things, and also many are addressing the specifics of some situation. But I'll talk about the generic mechanism right now. So some have been identified as simple and effective ways to reduce the exposition with the ventilation system, essentially. So generic ventilation here. So the first thing is air exchange. So you need to dilute these contaminants, these aerosols, and you can do it two ways. First, by a fresh air intake into a space, into a room, into a plant, into a classroom. Or you can evacuate the stale air, or do the two with a two-way exchange. So that's the first thing, changing the air. That's what we used. That's what we're thinking of when we're using the air change per hour calculation. So the ACH I just referred to earlier, and that was referred in the article as shown. So the number of time, the volume of the air would be replaced in a room. It's essentially the air change per hour. So if you have 2 air change per hour, would mean that you fully replaced 2 times the volume of air. So I'm not going further into that, but just that's the first thing. Second thing is filtration. If you don't have capacity in some space to exchange the air, so you can take care of the one which is already there. So you put filtration. Proper filtration here, because you'll need to be able to capture the small particles. Aerosols here are the size of a micron, typically up to even below and smaller to 1 micron, but typically from 1 to 10 microns and beyond that on both directions. But as soon as you've been able to capture a majority of those within this range, up to a micron and a bit lower, a bit smaller than that, you're having an impact, a significant impact, even a substantial impact. So filtration with a small note, proper filtration. So with the capacity to capture small particles, micron size. And third, indoor air quality monitoring. So IAQ monitoring, for example, we've heard a lot of CO2 monitoring in the last few months in this pandemic, but there are many different ways we can do indoor air quality monitoring. But monitoring is another key tool here to minimize risks and identify risk as well. We can also think about temperature and humidity control. So for example, on the temperature side, you want to stay within, I would call that the comfort zone. So 20 to 24 C, typically 22, 23, that's a good range, not to help much the virus itself. But even more important than that, it's controlling humidity. So relative humidity must stay within the 40 to 60% range as much as possible, because when it's too dry, especially when it's below 40%, the micro droplets, which are in fact the aerosol we're talking about, tend to get even smaller. And when they get smaller, they have the capacity to glide on for a longer distance and an even longer period of time in the air. So that's more difficult to get if you don't get rid of them. And you get when people get in the room, they have more chances get them right before the system. So you want to have humidity which is in the 40 to 60% range, beyond 60%. So when it's above that, then there are other health issues that can be coming. So you don't want to have an air which is too humid in a space where people are working, or people are, for example, students are studying in a classroom for hours. So 40 to 60, that's an important range as well. So every space, every worker's workplace can be monitored and optimized to minimize the risks that are associated with COVID, but also improving the air quality. So I've shown the ASHRAE, but there are others as well, such as, I'm just trying to show, so whoops, one slide less. So the RIVA, which is the Federation of European Heating and Ventilating and Air Conditioning associations in Europe. So that's a big federation. So they're coming with similar recommendation. You also have recommendations from the MIT, from Harvard, which is not there, from COVID is Airborne, a group which is from scientists from around the world, scientists and engineers as well. And many are recommending these solutions I just talked about. And what they're coming with, it's always through dilution, which is the first reason for ventilation. Think of it as reducing the amount of aerosol in the air. So that's another way to talk about dilution here. But the second role, there's a second role for ventilation, is also to reduce what we call resuspension. So aerosols that can be caught back in the air. So it's because the aerosols and small microdroplets can stay for some time in the air, as I said, they can glide, float, and then they can set on some places. And with when you don't control the air quality, they can just come back in the air, and with the people, the occupants coming back as well. So you have a second chance to infect people with the resuspension. It's much smaller than the first chance, but still there is. And with new variants popping up, so we don't know how much they will be able to survive in those in these conditions. But this is the second reason, and it's not to be neglected. It's not insignificant as well. So in such a situation, and in many others, ventilation is used to get rid of a diversity of contaminant, not only the COVID, the SARS-CoV-2 that caused COVID, but also the other contaminants that are in the air. So you have multiple reasons to add proper ventilation in a room, and it's shown in the schematic you see on the slide on the right side. All the things that ventilation needs to be doing. But one thing it should not be doing right now with COVID threatening the workplace is maximizing recirculation. We should not. It should be when you have a workplace with ventilation, I should start with the proper things. So when you have a workplace with ventilation, what you want to do is fresh air intake and stale air exhaust. So you want to evacuate the stale air. Many ventilation systems in their, I would call that their conventional or normal operation, which recirculate the vast majority of the air within the room. It's to save energy, essentially. But that is counterproductive with when you want to control a virus like an airborne transmitted virus like SARS-CoV-2. So you want to minimize this recirculation and maximize the fresh air input, outside air input. So first thing to look at is if it's possible to do that with the systems which are in place. Sometimes it is not because of the way they're built. Sometimes it is not as well because of their capacity. So first thing to look at is this. If it's not possible, then you look at the filtration I was talking about, proper filtration. So you would think of high performance filters like HEPA filters, HEPA filters. So HEPA filters are MERV 13 and more filters. There are standards, and I will talk about that later on in talking about air purifiers. So these standards are made to give you a capacity to evaluate their capacity to capture the particles in terms of the size of these particles and in terms of the percentage of captured particles they will have taken. So the highest it is, the best it is essentially. So a MERV 13 filter is better than a MERV 11, which is better than 7 or 8. The issue is in many conventional systems, MERV 7, MERV 8, MERV 9 are the one which would have been installed at the beginning because they respect the code, they respect regulation, definitely, but they're not able to capture in a significant way really small particles such as the aerosols that we're talking about. So proper filters are important. Another thing that you can do in the workplace, and I'm giving here an example which was prepared by John Udyk from Occupational in Ontario. So it's a self-assessment tool. It's a preliminary evaluation of the situation. This was done specifically for classroom, but with some key numbers, some key metrics. You're able to evaluate the potential risk and find ways to mitigate them. So the idea here is with some key numbers like the ventilation rate, if there is ventilation in the room. If there is none, it's 0, simple. If there is, and you can evaluate it, you put that in a spreadsheet like this. You also had the filtration characteristics if there are. So for example, the MERV standard I was referring to, so you can put the type of filters that are already in place. And you can also, if you have monitored for the specific room, the CO2, the ppm of CO2 in this room, so you can also add that. And this spreadsheet will give an evaluation with colors, by the way. So green, yellow, red, red being the worst case and green being the best case, essentially, where you're placed and what could be added or modified in this classroom, for example, to improve. So whether it's ventilation, if it's possible, so fresh air or outside air intake, whether it's a filtration, portable filters, like the one I would talk about in a couple of minutes, or other ways. So you have this capacity to validate where the situation is and what it can be if we modify this or that. So you can compare different solution, and with limited resource like it is in every workplaces, including schools, definitely, you can pick and choose what you're able as an organization to afford to make sure that people are safe in this room and using the best choice rather than those who would not have impacted the most. Another thing I wanted to highlight is there are sorry, it's kind of slow when I'm switching slides right now, so I'll try to, okay. So it's the air purifiers I was referring to earlier. So what is the value of air purifiers? Has been questioned so many times in the last year. So they are really an effective way, an effective tool in the toolbox. They're not the first thing you need to look at. First thing is always fresh air intake or ventilation, as I defined it earlier. So this is the first thing to look at. But if you cannot have fresh outside air intake in the room or increase it if it's needed to be increased, then filtration is the second best choice. And this is a good choice anyway. Proper filtration is referring to the level of, I would simplify that, of the standard the filter is referred to. So MERV in the commercial ventilation system is the reference standard in North America, essentially. MERV stands for minimum efficiency reporting value. So as soon as you're having a MERV 13 and above that, you're in a good position. Below would mean that you're capturing a smaller fraction of those microparticles, micro droplets we're talking about. HEPA filters, all HEPA filters, whether it's HEPA 11, HEPA 13, 12, and so forth. The bigger is more in the medical realm, but even the HEPA 11 are able to capture those small droplets, those micro droplets, which are the aerosols. So HEPA is already a good thing. A true HEPA, don't just look at the true HEPA to make sure that it's a real one. That's something that's an equivalent, which is not essentially. So through HEPA or MERV 13 and better, this is the key thing to look at. The CDC, the EPA, I was talking about the ASHRAE, and so many others are referring them as good solutions as well. What you don't want to see in a filtration system, it's all the other features that are often coming with air purifiers. So ionizers, ozone generations, and stuff like that, because they're generating byproducts, chemicals that you don't want to deal with in an environment which is not a controlled environment like a laboratory. So in special cases, they're fine. As I said, a lab, it's okay. Some in healthcare setting, in some special room, that's fine, because the whole system controls really well the air. But if you're in a shop or a workshop, or if you're a manufacturing plant or in a classroom, you don't have all those tools to really accurately monitor the air and all the chemicals that might be in this air. So you don't want those special features. You just want a good filter and a proper capacity. So the capacity of the system will be driven by the fan, the blower, which is in the system. So you need the capacity to filter a sufficient amount of air per hour to make sure that this filtration will be really sufficient in this space. So the bigger the room, the bigger the flow rate that the fan will have to generate. And this is, in fact, just directly linked to the air change per hour I was mentioning earlier. So here it's we're talking about the CADR, the CADR, which is giving an estimation of the volume of air that is treated by the filtration system. I'll not go into further details. There are plenty of resources, and I'll give some at the end of the presentation. So.
Thank you, Stéphane. I really appreciate that, to sharing all those resources. All the slides will be able to share to the folks here who register. So would you like to wrap up your session? Then we will have the next two speakers to present.
Yes, I'll do that in less than 2 minutes if you'd like to finish.
Awesome.
So just wanted to add another question which is coming up often is the Windows opening solution. So Windows open is a temporary measure. Don't think of that as a permanent thing for different reasons. Just in two main reasons. First, in Canada, it might be quite cold. We all know that. That's the one which everybody knows. But the second one, which is even more important, is wind direction is driving the number of CFM or liter per seconds you'll get through this window. So if you're facing the wind, that will be great. But if you're on the opposite side of the building, that would be the opposite thing that you'll see. So you'll have, you might even have the air from within the building going through the window and getting outside rather than getting in. So you'll not be solving your issue. So for some temporary reason, you might need to open a window, and that will be a good thing. But that needs to be temporary. That's the key word here. Second, the other thing I wanted to mention quickly, we can think about the roadmap. Don't want to read everything here, but WHO, so the World Health Organization, released a roadmap a couple of months ago talking about how to improve good indoor ventilation in the context of COVID-19. So here the keyword is roadmap. It's a way to go and improve the situation of a specific workplace. You start from where you are, evaluating the situation, and then you add whatever tools and whatever ways you can make to improve. And it's coming down to the recommendation I gave earlier, essentially, plus a couple of other things. But this is a good way to approach a situation. Rather than waiting to have the ultimate solution, you start right away improving the situation, the context, and then you continue down the road. That's a good approach. Ventilation and filtration is definitely in the hierarchical control. It's one of the layers. The next speaker, Simon, will talk of another really important layer, which is masking, and masks are another important one. So I just wanted to make sure that everybody understand that I'm not putting ventilation in contradiction with masking. They're working together and they're helping workers all together. If more complex solutions are needed, then an interdisciplinary mindset should be used as much as possible. So having people from the facility managers, of public health, hygienist, occupational health and safety indeed, and engineering support, and those people coming together will generate the best of the solution in the specific context of the workplace we're looking at. So that's it for now. Thank you for the time. Thanks.
Merci beaucoup, Stéphane. Thanks a lot. I know that we're running a little bit behind schedule here. Simon Smith, who's a respiratory specialist, is next. And I'm going to cut back on my bit about cleaning and disinfecting so we have a little bit of time for questions. Simon. Stéphane, can you stop sharing your screen, please? Great.
Simon, we can't hear you. At least I can't. I don't know if anyone
Yes,
else
no,
can.
and I can't either. The joys of Zoom technology or other technologies. Well, Simon's getting his system working there. No, we still can't hear you, Simon.
Can you try to unplug your headphone and plug it back again and try that way?
Now,
There we
Yeah,
are.
there we go.
sorry about that. It's
Awesome.
happened, isn't it?
I
That's
think
how-
it could be a little louder.
Just talk a
Okay.
little bit louder, that'd be great. Thanks.
I don't know, but I'll have to shout. Okay,
That's
can you
good.
see a screen now too?
Yes.
Apologies for that. That's just what happens. I'll go fairly quickly. The slides will be available afterwards, and I'll just try and make this advance. Here we go. Yes. Thanks very much again for the introduction and for the previous speakers to cover many of the aspects on protection. I'm covering respiratory protection, again recognized as the lowest level in the hierarchy of protection. And I hope as people are from a working background, they are probably familiar with many aspects of use of respirators in workplaces. But just to say, the world we are familiar with respiratory protection in workplaces is a very well-controlled one. There are programs to manage protection. A lot of assessment goes into ensuring we know a lot about the environment that people are working in. And then there are protocols to make sure the right kind of respirators are selected. And there are also very good certification systems to make sure that the respirators that are provided are capable of meeting the task to remove contaminants from the air and provide the wearer with necessary protection. So that's the world we've been living in, but in the last couple of years, of course, we've had the issue of respiratory protection for the public. And this is much more open. We have these mask mandates that may come and go, all or nothing. There are many varieties of products, some based on style, some based on function. There aren't many standards. There are more and more every few months, and there aren't any in Canada right now for performance of products. But there's no requirement for users to select them like there are in workplaces. And it's the manufacturers who certify performance when they exist. And of course, there's very little control over wear compliance. The idea also is that this is not only for wearer protection, but also source control. So we have these two different worlds, and I'll be sort of flipping between them. I'm not going to spend too much time on the respiratory protection side in workplaces, because I hope that is more familiar with people. But again, there's information in the slides. One thing to take away is the 3 Fs. So we've had the 3 Cs and other things with some more letters here. But things to remember about respirators and protection are filtration, fit, and function. And we need all 3 of these in order to have effective respiratory protection. Just focusing on 1 or 2 will not suit. So filtration, of course, is how well the material is removed by the respirator itself. The fit is how good the seal is to the breathing zone, because if air leaks around the periphery, it doesn't matter how good the filtration is, you're not going to get protected. And the function is perhaps something people think of less, but it's important. And that is how well does the respirator allow the wearer to do their job? Does it interfere with communication, so they have to remove the product to speak effectively? Does it get too hot, get too burdensome to wear? And so having features that make it functional are also important, because if you're not wearing it, you're not getting protection. So all of those things are important. Again, a slide here showing a comparison of what we might call community face coverings. That's a European term, but that's for the general masks that are applied to the public. And unfortunately, the word mask is spread with a broad brush and applies to many different kinds of products. So we've tried to focus on some different wording. Surgical masks and approved respirators. You can see at the bottom there, there is a sort of scale of the relative capability in different areas, the 3 Fs and then others that are identified. And so overall, the approved respirator scores the best in all of those categories. But of course, that comes in every sense with a price. They're more costly. And we had issues of shortages earlier on, which led to some of these other solutions being applied, even in workplaces where perhaps they shouldn't have been. I'll move on fairly fast. This is a graphic from Masks for Canada, an agency promoting mask wearing in Canada, showing relative filter and fit effectiveness for different styles of product. And so going from the cloth masks through to workplace respirators, the filter effectiveness and the fit effectiveness increases. And there are various techniques for improving those, as you see. We've heard sometimes that the N95, and certainly N95 is used, unfortunately, to name a product. It's actually a test standard, so you can have different styles of N95 respirator. That has been said to be the gold standard. But I think if people are familiar with workplaces, you'll know that the N95 type filtering face piece on the right here is in fact the lowest level of effectiveness, and there are products then that then go up from that to improve the level of protection and other factors of wearability, but that comes again with other factors being the physiological burden, the training and logistics needed to maintain the system, and the price. That means you would only select the higher levels for specific situations of need. But just to say, in workplaces, we can go a long way further than just the basic filtering face piece type respiratory protection. The 1, 2, 3 there, actually, I'm just going to refer to later on when we come to some selection guidance. I'll move on fairly fast, but just to mention, the filtration of particulate matter relies on a fibrous web, and there are several different ways in which these fibers remove particles. It's not just filtering like a tea strainer. It's not just the mesh of the web that causes the filtration, but a lot of this comes down to the electric charge interactions between fibers and particles. And so we get a range of mechanisms, and that leads then to a situation for filtration where there's actually a minimum level of protection, and some is better for lower particles, some protection is better for higher particles. When it comes to testing, filters are tested at that minimum level of protection. That's where the 95 comes from in the N95 filter. When it comes to the sort of particle sizes that are carrying the viruses, the diagram that Laurence showed, in fact, we are in a level where there is very high efficiency for protection. So we can be sure that when we are talking the sort of equipment that has these fibrous webs in it, we're getting very good filtration. When it comes to fit, I'll not stay on this one. People should be familiar from workplaces that there are 2 fit test methods used, qualitative and quantitative. And it's also required every time that a user does a user seal check when they don a respirator to determine that it is fitting properly. You use the qualitative and quantitative fit tests for first selecting and then routine reassessment annually or more often. That's I guess how fit is covered in workplaces. Again, there are no real fit protocols for community face coverings. The other thing was the function, and our slide just shows a few things affecting function. The effect on the physiology of the wearer, the ability to communicate, interference with their work through the bulk of the product, or it being dislodged when they do certain functions. And then there are some things like shelf life and the ability to decontaminate when needed, if there's a shortage. So that all of these things are important in function. And if one is selecting products, these are things to consider. I mentioned that new Canadian standard, which is going to be coming out, is already issued and will become part of a new certification system. In that, there are going to be criteria around the physiological burden, and particularly the airflow resistance of the product. That's going to be identified for N95s in particular ranges, so it will aid in the selection of respirators for low burden needs and better functionality of workers. To mention selection, just to say this is something that appears in the Canadian standard, and this is unique in the world when it was issued, and is still one of only 2 standards in the world that actually gives criteria for selecting for biological hazards. And this is undertaken through a control banding method, where the factors of the nature of the hazard, the generation rate, and the controls applied or ventilation are in fact considered and put through an algorithm. They're reviewed on a 1 to 4 scale, and the factors used in that scale selection then go through to advise on a particular level of protection. There's a complicated list here, but you can read that at leisure. Just to say, by using these factors, we come up with a very simple algorithm that can be applied. And this was devised actually over 10 years ago in response to the first SARS outbreak. It's been available. It hasn't well been recognized by health authorities or governments recently, but it is in the standard. And what it does is provide conformance mainly with expert opinion that was existing methods of selecting respirators, but it fills some gaps. And particularly it considers ventilation. So we have a selection guidance system where you look at these factors, and one of them being ventilation, it may recommend a different respirator depending on the level of ventilation in the particular workplace. An example there for COVID, aerosol generating procedures, where we've traditionally said, well, that's the filtering face piece N95 type. This guidance would indicate that's suitable where there's high ventilation, good ventilation. But if you have a situation of corridor healthcare, for instance, patients in hospital, in corridors, where the ventilation levels are lower, it may mandate higher level protection to recognize that poorer air exchange. So just one other thing, we're talking about the use of face coverings by the public. This diagram shows a study results that have indicated the level of protection offered for the person who is infected or releasing material and the one who's susceptible, with different combinations, and the infection risk going up. So the worst is at the top, and that is where people are wearing both infected and susceptible wearing surgical masks, and the best option is at the bottom where they're both wearing fitted respirators. FFP2 is like an N95. It's slightly different test methods, but it's comparable. So we can see that it is better if people in the public domain are wearing approved respirators that have some level of fitting, and that does give overall better protection, but there are combinations that still offer good protection. So with that, I'm afraid I'll stop, just to say, recognize that all masks are not the same, that 3 Fs are important: filtration, fit and function, and that there is guidance available in the Canadian standard, and there's a link to a viewable version of it in the document. Thank you.
That's great, Simon. Thank you. For the Manitobans in the crowd, I wanted to point out that what came out of the original health hazard regulation is still in the current regulations when it comes to respiratory protection. And in fact, Manitoba is one of the only places that in Canada that actually says that to use the CSA standard, and I think it's section 6.15. Simon, if you could stop you sharing your slides. And I'm just going to very quickly, I wanted to just very briefly talk about cleaning and disinfecting, because we've been talking about the various ways of coming at things, about programs, about the need for ventilation, about respirators. But one of the things that everybody has been is the thing to do in this pandemic so far is cleaning and disinfecting. And I would like to argue that it's really a bunch of hygiene theater and unnecessary. And here's just one very classic example of some folks over at University of Guelph went out and did hundreds of swabs on shopping carts and said, guess what? All the measures that we have in place are working. Those disinfectants are really working. If you touch the virus, it's not there. But did they answer the basic question, was the virus there in the first place? So I won't go over the difference between cleaning, disinfecting, and sanitizing. I'll refer you to the MFL Occupational Health Center handout on this later. But just to say that even some people, including the Manitoba government, seem to confuse it. Hygiene theater is what we're really seeing when they're all this spraying and wiping and all that, especially if the virus is in the air. And clearly Manitoba is out of step. It keeps on talking about doing twice a day cleaning and disinfecting, encourages the use of chlorine and things like that. And when they actually refer to the CDC, and the CDC says, guess what, folks? Soap and detergent will actually do the trick, and you only need to clean once a day. There are a variety of things to be concerned about here, and you rarely hear about this, but most cleaners and disinfectants, other than the all-purpose stuff, have all kinds of nasty effects. And in particular, something called quats, which are found in things like Lysol and Clorox and things like that. They're the chemicals that end in something like ammonium chloride, have all kinds of effects. And one of the things I discovered the other day is that in hearings in California in March, there was a presentation showing that researchers found when they were comparing the level of quats they found in the air in houses during the pandemic to other kinds of things they found in the air, quats far exceeded what they were finding for other kinds of chemicals. And it was all linked to disinfecting in the pandemic. I would just suggest to you that if disinfecting is really needed, we do know that there are options. There are resources on this, and probably the most common option is hydrogen peroxide. And you will, in fact, find these on the Health Canada database, but watch out because sometimes they come with other things you don't want, whether it's these benzalkonium chloride, which is one of the quats, or something called peracetic acid. If you mix that with hydrogen peroxide, you're getting something that causes asthma. And that's what the quats do, amongst other things. I would suggest that soap and water is just fine. And microfiber cloths are really very helpful. And so if you want to know more, this is the handout that I did for the Occupational Health Center more than a year ago. And the basics, or the fundamentals, as Brent Rusin would say, include that cleaning, disinfecting, and sanitizing are different things. Employers are responsible still for providing health and safety jobs. Workers have to be trained, know how to do things properly. And the most effective way to deal with this thing is prevention. If you want materials about actually disinfecting and the best practices, I worked on this handout that's available through the New Jersey Education Association and the Work Environment Council in New Jersey. So my basic takeaways are that hygiene theater is unacceptable and unnecessary, and that our health and antimicrobial resistance are at stake. Quats are linked to antimicrobial resistance. I think we have to stop wasting money, clean the air, not surfaces, use the least nasty method for a product, or this informed substitution, be sure we're actually not using something that's going to cause problems, and we need to protect workers' health. So that was my very brief version of a presentation. People who know me will know that I've done a whole lot more. And in fact, the book that I was mentioned when we were talking earlier, I just finished a chapter about cleaning and disinfecting, and I'm about to do another one. So what I'd like to do is, I saw a couple of questions, and particularly Simon. I saw that someone I know, Lisa Cooper, has a question about the fit tests for N95s and whether people wearing them in the community really need a fit test.
Oh, thanks. Practically, it's obviously a big challenge. You can hear me? Yeah, just Yep, good. Thanks. And so I think this does relate to the last diagram I showed, which did indicate that there is a value in having a fit tested product, but it's not something that's being practical. We'd have to get to the best we can. The user seal check with the hands over the product is perhaps the best we can achieve. So that is better than nothing at all. But unfortunately, because of the difficulty in making available fit test equipment for the public, we're not really practically going to have fit testing for masks or respirators in general use. Sorry about that.
And there also is a question here from Anne Rochon Ford about the materials that are used. And this is something I know that Anne has brought up with me and with some others. And I know it's probably a long conversation. Have you got a short answer for it, Simon, at the moment?
On the materials themselves and the health effects, unfortunately, again, that's something that's been little studied from the manufacturer side, but it is something that's recognized. On the issues of biodegradability and so on, that again hasn't really been an issue hitherto in discussion, but it now is appearing in some of the standards. There are goals for ensuring that product is recyclable. And again, when we work on the next phase of the Canadian standard, that is going to be something that's going to be assessed as well. As statements on that will be included to encourage manufacturers to make recyclable product. It's a tough one though, because of the issues of needing certain kinds of materials in order to get the best effectiveness for filtration. Thanks.
Laurence, I see you have your hand up.
Yeah, the Aerosol Transmission Coalition has had some very interesting discussions recently with representatives of the Canadian manufacturers of personal protective equipment. And those representatives made it very clear that they are working on recyclable materials for respirators and masks as well. I think the manufacturers themselves, some of them do recognize these environmental issues and other health effects. For example, you mentioned, the questioner mentioned endocrine disruptors. So these are all on the table. I would just point out one thing, that in the short term, the protection of the population against the hazards of SARS-CoV-2 protection of the public and workers against SARS-CoV-2 is a lot more serious than what little we know about the long-term effects. So I would encourage people to switch over to use in public and at workplace to respirators rather than masks. Thanks.
I think that we also would probably try to go for the precautionary principle here and push for more work to be done about the materials that are being used, so we don't have to be worrying about breathing all these, breathing other chemicals. One of the things that I just wanted to bring up is that as a coalition, we wrote earlier, Marianne spoke to this, our first letter went out to various governments, including the Manitoba government. And we got a letter back from them saying, oh yes, we're really paying attention. But if you look at the documents and the actual guidance that they're giving and the practices and what the workplace safety and health inspectors and hygienists are actually able to do, it seems to me that Manitoba is a good example of being out of step with the science. It's not protecting workers, and that there are, and not protecting the public all that well. I understand that they're now talking about sending patients out of the province because the load that there will be in the hospitals because of people getting sick. So if they don't accept that the virus is in the air, and the word aerosol, I think, appears only once on the whole COVID-19 page of the Manitoba government. I don't think the word airborne appears there. So I'm hoping that efforts like, I saw Luann Kern is on here, the people who, the Safe Schools Manitoba, the Wolseley, Laura Secord School Parents Association and others, the efforts that they're making, the people on this webinar are able to support that, we're happy to help. We're happy to, provide background information, provide more information for people, and out of step would be understated. Yes, I'm trying to be polite. I know we're 10 minutes over time. So I see Eduardo asks about employers in Manitoba have a good ventilation system in their facilities since we haven't heard of COVID cases in workplaces. Well, I would suggest that's because of the way it's being reported. And certainly there have been COVID in workplaces out in Brandon in the Maple Leaf plant there. There were 2 workers that died in what used to be the Granny's plant at Bloomthorpe, if I'm getting the name of the town right. Healthcare workers certainly have been infected in large numbers in Manitoba. We can provide the data on that. When it comes to ventilation, I would remind people that the workplace health and safety regulation actually requires Manitoba employers to provide good air and to make sure the mechanical systems are actually preventing people from getting sick. It's a unique, well, maybe not unique, but it's an important part of the regulation. And it was part of the conversation that we had almost a year ago with John Odike, Lisa Brosseau, and myself talking about ventilation and linking it to Manitoba regulations. There was COVID-19 at Boeing, says somebody here. I'm just looking to see. Healthcare experts have been stating COVID is not virulent and airborne as chickenpox. So N95 use is not justified. What would we have to say? The short answer is they're wrong. Does anybody else have a specific comment?
Yeah, I'm sure a lot of us could comment on that. The comparison, like trying to make conclusions about whether something is airborne or not from how infectious it is based on a fallacy. I mean, we had this at the very beginning. It was said COVID is not as infectious as measles, therefore it cannot be airborne. One has nothing to do with the other, in fact. How infectious it is has to do with how much you have to absorb, inhale, whatever, be exposed to get infected. Measles is very high up on that scale. The original strain of COVID was not, it's true, but with these new strains, Delta and now Omicron, it's certainly inching up to be as infectious as some of those other diseases, measles, chickenpox, that certainly have been recognized as airborne. But in fact, something can be airborne, and yet you may need a whole lot of it to be infected, and that's why that conclusion has been drawn that it's not airborne. But it is. There's plenty of evidence that it is. So the degree of infectiousness does not lead to a conclusion whether or not it is airborne. And given that it is airborne, given the evidence we have, certainly good respiratory protection is essential when you are potentially exposed to an infectious dose in the air.
And so is ventilation, and
Right.
fewer people in spaces for less time. Laurence.
So I would just ask a simple question. When was the last time anybody on this conference saw people sneezing and coughing in public and exercising very poor public health protocol? I don't see anybody sneezing and coughing in public anymore. But we're in a 4th wave, nationally and internationally. So the face coverings, all the public health measures that have been put in place to date by our public health officers have not stopped the pandemic. So judge the evidence by yourself. Don't make false comparisons between chickenpox and this virus. That sounds to me like some excuse making. Protection against aerosols is the aerosol approach, aerosol understanding to continued infection is the only thing left on the table that explains 4 waves. We're not protecting publicly against that. So I think the evidence speaks for itself.
Thanks, Laurence. Stéphane.
I would just add that there are evidence on the two sides of the equation. So evidence on the scientific nature of the, I would say that the airborne nature on the scientific side of this, the SARS-CoV-2, but also on the risk mitigation tools. So masking, N95 or FFP3, as I said earlier, or ventilation and filtration have been proven in studies as being reducing the risk. Just last week, a study in Switzerland shown that in classrooms with ventilation, the infection rate was 6 times smaller than with classrooms without ventilation, 6-fold. That's quite a difference. And that's an example of the real nature of this, the transmission. So there are proofs, so many proofs now. Early 2020, maybe some people could have said it's not sure, we've heard that. But where we are right now, after almost 2 years, there are proofs so from all directions on that front.
I see a number of questions here. Dave, I'm just going to go backwards. Dave Fritz, thank you for yours. There is no, as far as I know, there's no consensus about what the infectious dose is. And I think people are still working about on the actual measurements. Someone also had a question about this question of droplet transmission. Let's just be clear. Droplets are a form of aerosols. Aerosols are particles in the air that come in different sizes, and so-called droplets are just larger. And in fact, the question is workplace exposures. How do you know it's not droplets? Well, the ferret experiment, if you go back to what Laurence showed us with the ferret experiment, that kind of thing is being done in workplaces regularly. And certainly if you look at things like the meatpacking plant workers, I don't think that that there's any evidence there that it's the larger particles. It's because it's in the air. They are working close to one another. But when, and I could show this actually, maybe this would help. Hang on just 2 seconds here. I'm just going to share something that shows how this works in terms of things coming out of our mouths. Let me just. So, and this goes back to an earlier question about aerosol generating procedures. Actually, if you look at what, I'm just trying to find the right, here we go. If you look at and think about it, people are aerosol generating procedures, whether we talk, cough, or just breathe. And so essentially, the aerosols are what some people once called crud in the air. And the size determines how they behave, what's inhaled, how far they get into the respiratory system, and how far they go. And so this is the nice little graphic that I quite like, that I will that shows the difference between just breathing, going all the way up to shouting or singing, where in a closed space in an hour, if somebody had the virus, they could be emitting about 1,500 so-called infectious doses, although we aren't quite sure what that actual amount is. But the idea is that shouting or singing, talking, or even just breathing is going to be generating aerosols. And I saw another question, Lisa's question about eye protection. Is it a good idea for the general public to be wearing it? My understanding, folks, what's your take on that?
I can say that there have been a few cases reported of ocular transmission, and it usually has been at close contact when there was spray. I mean, go back to droplets. Yes, droplet transmission can happen. It really means that you're so close to the person that you are sprayed or hit by the larger droplets. So there was some evidence that that happened when it kind of hit people in the eye. Essentially, people would get pink eye or something like that as maybe a first sign or symptom of COVID. So that kind of gave rise to the requirement for eye protection. That is something that is generally agreed that it should be worn at close contact. It is not generally worn when it's mainly a matter of far field or long distance contact.
There's another question here about from Jennifer about transmission having to do with the unvaccinated and how far apart were people in the pictures. Just to answer, it doesn't, the people in the picture, that was just an example, but if you go to the one where the sort of the room that fills up without ventilation and without any kind of source control and without any kind of things to stop people inhaling, certainly people, if someone is infected and they're sharing air, the odds are that they're going to share it. And certainly the numbers in Ontario these days with Omicron, I mean, just the expansion of it, whether or not people are unvaccinated. At this point, we don't know how well, at least there's certainly questions about how well the vaccines work against Omicron. So even if you are vaccinated, if you do get infected, the odds are that you're still going to get some kind of be affected in some way. It's my understanding. Laurence.
One of the things that impressed me the most in the beginning of the pandemic was the statement by Dr. Tedros of World Health Organization. Tedros said very bluntly, and continues to say today, that we have individual responsibility, we have countrywide responsibilities, and we have international responsibilities. With regard to, I'm sorry, I just lost the point. The pandemic continues. The difference between a droplet and an aerosol becomes increasingly, if I could use the word, pedantic. A little bit of nonsense and baffles.
Sorry, but Laurence, we can't hear you.
Infection contains infection. It's going to infect. Whether you're at close range, splatter in your face from a cough, or you're at distance from aerosol. We have to teach ourselves not to take account of this type of, they're both infected particles. So there's a variety of measures that we can take. Personally, when I go into public, I wear an N95. Mm-hmm. I mean, that's my approach. Lots of people don't want to do that. There's all kinds of excuses. I've heard in hospitals, it's hard to breathe through an N95. It's better through a surgical mask. I've heard that from the healthcare workers. I find that to be a false dichotomy. Protect yourself. Protect the people around you, protect your family, protect the workers, protect yourself, protect the workers. For me, it's quite simple. Take the highest measure you think you need in public.
Mm-hmm. As Tiffany says, we should wrap up. I just want to point to Andrew mentioned that Denise Coe, the Chief Occupational Medical Officer, said that the Maple Leaf cases were mostly out of the plant. And I would argue that that's a classic response, that too often during this pandemic, we have seen efforts, or we have seen people doing their best to point to things happening outside workplaces, to blame workers, rather than to say there's something going on in this workplace. And certainly when you have 900 workers infected, as they did in High River, for example, and I forget there were hundreds affected in Brandon, it can't just be what's happening outside the workplace. Stéphane, this question about ventilation from Christy, cases in where you're talking about droplets being propelled, but I would say aerosols being propelled, and not everybody getting sick. What's happening? Do you see that question?
Yes, we've seen in the planes and restaurants where droplets are propelled by ventilation. Yes, it might happen for the reason I was explaining earlier. that's why we don't want to have recirculation as much as possible. So if you have, and just make sure that you understand the difference. Real ventilation takes fresh air to a room and exhaust the stale air. But typically in the common jargon, it's including even the air conditioning system, which has just a recirculation thing. So we have seen, for example, there was a big case in South Korea last year, which was talking about restaurant contamination by the air conditioning system, the ventilator, the fan of the air conditioning system. So yes, that might happen. But if you're coming with fresh air and if you exhaust stale air, that cannot happen, as you said in your question. So that's just an important thing. So fresh air intake is the key to make sure that you're not moving back the aerosol in front of the people.
And Michelle has an interesting point here about how close contact and cases are being counted in schools, which is similar to the kind of thing I know in Ontario, where someone I know who's a public health nurse was going into schools, this was like a year ago, and was being told that if the teacher was wearing some kind of face covering, he or she was not a close contact and they weren't going to be counted or notified, told to isolate and those kinds of things, which goes against what all the work that Simon has done and the knowledge that he has, and the same with the rest of us who are involved with this kind of thing. So any last questions? And if not, as I said, we're more than happy to try and support people in Manitoba, because I know it's really hard trying to persuade Dr. Brent Rusin and others there that the words airborne and aerosol might want to be the basis of their fundamentals, and that there are things that need to be done to protect workers and to actually enforce the Workplace Safety and Health Act, as I tried to do many years ago.
On behalf of the Occupational Health Center, thank you, all of you, a group of members of the coalition, you know, Dorothy, Marianne, Simon, Stéphane, and Laurence. What a great presentation. Really, really great information you pass out to the audience here. So we got lots of great comment on the chat. So everything has been recorded. So I will send out the record session with the slide, and also for the chat recording to as an attachment to send out to who registered for this session. So thank you again and also appreciate for all the audience staying behind the schedule to watching all the Q&A session too. Appreciate, you know, all your participation. So thank you all.
Yep.
Hope all of you have a happy holiday and stay safe all the time. Okay, bye. See you.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thanks for inviting us.
Yes.
Take care.
Thank you.